Hello, my name is Emma Waight and I'm excited to present on behalf of my co-authors, Temporal Trends, Clinical Characteristics and Sociodemographic Profile of Post-neonatally Acquired Cerebral Palsy in Australia, 1973 to 2012, a population-based observational study. Before I begin, I would like to acknowledge that I am presenting today from the traditional lands of the Darramuragal people and pay tribute to elders past, present and emerging. So, what is post-neonatally acquired cerebral palsy? Post-neonatally acquired cerebral palsy is the consequence of an insult to the developing brain that has occurred after the neonatal period and prior to 2 years of age. There are many postneonatal causes of cerebral palsy, for example, head injury, infection, or stroke occurring in the postneonatal period. There are limited studies on postneonatally acquired cerebral palsy, with a major focus in our field being around pre- and perinatally acquired cerebral palsy. On the Cerebral Palsy Register, the known cause of postneonatally acquired cerebral palsy is included on the individual's record. Knowing this provides important opportunities for prevention. Our aim in this study is to describe postneonatally acquired cerebral palsy in terms of temporal trends in prevalence, clinical and sociodemographic profiles, known causes, and associations between causes and sociodemographic variables. Prevalence data were sourced from the long-standing population-based registers, the Victorian Cerebral Palsy Register, and the Western Australian Register of Developmental Anomalies. Denominator data was sourced through the Australian Institute of Health and Welfare, the Victorian Perinatal Data Collection, the Australian Bureau of Statistics, and the Midwives Notification System. Data for birth years 1973 to 2012 were calculated per 10,000 live births, and Poisson regression was used to investigate temporal trends in prevalence. Cerebral palsy numerator data provided by all 8 Australian states and territories for birth years 1995 to 2012 were used to investigate causes along with clinical and sociodemographic factors. These factors included gestational age, sex, accessibility and remoteness, socioeconomic advantage and disadvantage, maternal age, and maternal Aboriginal and/or Torres Strait Islander status. Clinical and sociodemographic data was sourced from the Australian Cerebral Palsy Register, the Australian Bureau of Statistics, and the Hugo Centre for Population and Housing. A chi-square goodness of fit test was used to compare postneonatal cerebral palsy data against Australian reference data. Logistic regression was performed to assess the strength of association reported as the odds ratio between causes of postneonatal cerebral palsy and available clinical and sociodemographic variables. Australian reference data was sourced from the Australian Institute of Health and Welfare, the Australian Bureau of Statistics, and the Hugo Centre for Population and Housing. The ethics process, analysis, and interpretation of data, including those pertaining to Aboriginal and Torres Strait Islander people, were overseen by an Aboriginal researcher and listed author. In addition, the authors sought consultation about the interpretation of results from the Community Aboriginal and Torres Strait Islander reference group. Please note that being born to an Aboriginal and/or Torres Strait Islander mother is not considered here as a risk factor. Instead, being treated by a culturally unsafe healthcare system is what is considered the actual risk factor. A statistically significant downward trend in prevalence of postneonatally acquired cerebral palsy was evident in both Western Australia and Victoria. Postneonatally acquired cerebral palsy in Western Australia declined from 2.3 per 10,000 live births to 1.6 per 10,000 live births. Although prevalence fluctuated, the overall decline equated to 13% every 5 years. Similarly, in Victoria, postneonatally acquired cerebral palsy declined by 7% every 5 years. Cerebrovascular accidents were the most common cause of postneonatally acquired cerebral palsy, followed by infection and head injury. This is a very simplified table, and the one in the paper has much greater detail. However, when compared to Australian reference data, we found that children with post-neonatally acquired cerebral palsy were more likely to be born preterm, be born in remote and very remote areas, are born to teenage mothers, and are born to Aboriginal and/or Torres Strait Islander mothers. We also found that children who were born in remote and very remote areas were over 4 times more likely to have acquired post-neonatally acquired cerebral palsy through infectious pathways. Similarly, children born to teenage mothers were 3 times more likely to experience a postneonatal infection. And there were no other causes or sociodemographic factors that were positively associated. In summary, a statistically significant decline of postneonatally acquired cerebral palsy was observed in both Victoria and Western Australia between 1973 and 2012. Cerebrovascular accidents were the most common cause of postneonatally acquired cerebral palsy. Children born to teenage mothers, Aboriginal and/or Torres Strait Islander mothers, or children born in remote or very remote areas were overrepresented in this cohort when compared to Australian reference data. Infectious causes were strongly associated with teenage motherhood and being born in remote areas. In future studies, we will look at investigating causal trends to determine which causes have declined and which have not, determine which public health interventions these declines may be attributed to, determine which prevention strategies can be capitalized on and whether they are accessible to priority populations, and investigate whether new prevention strategies need to be developed. I would like to thank all the families for their support and allowing us to use their data. I would also like to thank the Australian Cerebral Palsy Register Group for their hard work and thank the amazing organisations that support this research. Thank you.